The next topic, Dr. Manju Bhate is going to speak on restrictive strabismus. She is a consultant ophthalmologist with LV Prasad Eye Institute. She has done her fellowship training in Westmead Hospital, Children's Hospital, Westmead in Sydney. She has worked there for a while and now has repatriated back to India and is working with LV Prasad Institute. Her areas of interest are genetic eye disease, strabismus, and she's going to talk on her work on restrictive strabismus in particular, and generally covering the strabismus with limitations. Thank you, Manju. Take it away from me.
Thank you so much, Sumita. Am I audible and can you see my slides?
Yes, yes, we can see.
Thanks. So at the outset, I'd like to thank the Asia Pacific Society and AIOS for inviting me to speak today. And I'll be taking you through some aspects of restrictive strabismus. I have no conflicts of interest to declare. So as we all know, restrictive strabismus is an incomitant strabismus. It's commonly subdivided as fractures in strabismus, that is following orbital wall fractures, thyroid strabismus after glaucoma drainage device, which can affect the extraocular muscles and the motility, the scleral buccal surgery, or it could be an unusual congenital or acquired restriction. And we'll cover some aspects of fractures in strabismus, of thyroid, and as well as some an unusual acquired restriction. So this will just be a case-based approach. So let's start with the first case. So this is 8-year-old child, and he fell off his bike, which is common in this age group, and he had a white-eyed blowout fracture. As we can see here, he had a acquired hypertropia of his right eye following a floor and a medial wall fracture. And here we can see that there's a large defect in the inferior wall and there's also entrapment of the muscle, following which he had a fracture repair. And so he underwent and then was referred to the strabismus clinic and underwent an exploration with recession of the inferior rectus of the right eye. And so he had much better cosmesis, improved ocular motility, and a resolution of his diplopia. He did have some limitation of up gaze and down gaze, as we can see in this early postoperative picture. Our next patient is a young lady, and she had a craniofacial trauma, and she had a fracture fragment which was impinging on the optic nerve. And she had an extra large strabismus, as we can see in the primary position photo in the middle here. She's got a large right hypotropia. So she initially underwent the fracture repairs and then was referred to the strabismus clinic. So this sort of her story spanned over a period of almost 5 years. She initially had an inferior rectus recession with a single horizontal muscle, the lateral rectus transposed to the superior rectus. Her hypertropia, the strabismus, did reduce from an extra large size to a moderate to large degree. We can still see residual hypertropia here. And then she had another surgery to transpose the other horizontal muscle. And as we can see over here, she is fairly cosmetic, though she had really poor vision in the right eye following the trauma to the optic nerve. Our next case, so I'm just going to take you through, it's not always this fracture strabismus like a fairy tale. And so this is the fairy tale of Goldilocks and the Three Bears. I'm sure most of you would be familiar or have enjoyed it in your childhood. This was like one of my favorites. So it's not always a fairy tale, by which I mean that bears are not friendly. And this little girl, I don't know what she was doing with a bear, but she had a bear bite and she had a fairly disfigured eye and face after that. So this is a photo after a lot of her oculoplasty repair that she underwent with the oculoplasty team, following which she was referred for strabismus management. And as we can see here, she has a restriction of motility in her right eye, pretty much all gazes, and also a restriction of adduction of the left eye. Following which the MRI, she was able to fuse with prisms though to a single image, and the MRI showed a normal architecture of pretty much all the extraocular muscles. There was some soft tissue hyperintensity, which was secondary to all the extensive surgery that she had. And then she underwent a strabismus surgery. She underwent a bilateral lateral rectus recession. We tried to see if there was a superior oblique, which wasn't found. And eventually, cosmetically, she was better, I would say much better than what she was to begin with. Although our Goldilocks was not quite there, but she was almost just right. So this brings us to one of our recent publications in JPOS, which is now online, which looks at the clinical profiles and the surgical outcomes of strabismus following orbital wall fractures. And this was a large cohort of 347 strabismus cases. Some of the salient features were that we had more of males affected. The orbital floor fracture was more common, followed by medial wall fractures. And the resultant strabismus was not just restricted, but also paralytic, and exotropia was more common, followed by hypotropia. And in the combined deviation, it was a combined hypo with exotropia, which we noted. So as we can see in some of these bar diagrams here, we can see that the floor is more involved and followed by the medial wall. And also in the deviation, it's the exotropia, the hypo and the exotropia, which is more frequent, followed by the hypertropia. And again, the exo, which is more common, commonly involved. Looking at the cases that went on to needing surgery, there were about 34 patients, almost 1/10 of the cohort, that underwent surgery for strabismus. And the preoperative diplopia from almost 80% was reduced to 15%. And again, the cases were a mixed bag of restrictive as well as paralytic strabismus. So again, this is just about the walls and the type of strabismus involved, and the detailed paper is online if anyone's interested. Moving on to the next common restrictive strabismus that we see is the thyroid strabismus. And thyroid eye disease is something that involves, or rather the sequelae of the thyroid eye disease involves the orbit, the extraocular muscles, and the eyelids. And the extraocular muscle involvement, again, commonly affects the inferior and the medial rectus. And so also all the other recti and the oblique, none is spared. It can be asymmetric, and very often the patient presents with a disturbing diplopia and an uncosmetic appearance. They've already had, if it's a tertiary care center, they've already had some sort of intervention, possibly by the oculoplasty team. And the aim as strabismus surgeons does lie in improving the and giving the patient a comfortable field of binocular single vision, both in primary as well as down gaze, and a reasonably good cosmesis. So this is actually one of my favorite patients. He's a 56-year-old gentleman, and he came with a very uncosmetic hyperdeviation of the right eye. So he had a thyroid eye disease. It was stable for over a year. He underwent orbital decompression of the right orbit, and according to him, the strabismus and double vision worsened after that. So he refused any surgery on the left orbit, like he refused a left orbital decompression. And as we can see the imaging over here, he's got like these massive extraocular muscles. And in his 9 position of gaze, his right eye cannot depress, his left eye he cannot elevate. And then so I tried counseling him. He refused surgery for the left orbit. So he underwent a staged procedure. He had a right eye strabismus surgery where the super tight superior rectus was recessed on a hangback suture, and the right eye medial rectus was also recessed. And he's still like this, much better cosmetically, and doesn't want any further surgery whatsoever on the left eye. I'm just going to wrap up with this last case. So this is a 3-year-old girl, and she presented with a subacute onset of strabismus. She was brought by her parents. They denied any history of trauma, and in her previous old photographs, she was orthotropic, as we can see over here. This is the photo of her on her first birthday. So when she came, this was just before COVID lockdown. And so if we look at her 9 gaze position, that left eye is just sitting locked into, or rather locked down in that particular position. And she's unable to sort of have any extraocular motility in that left eye. And this is her imaging. So the imaging revealed a bulky inferior rectus with increased signal intensity. And with a sort of suspected provisional diagnosis of myositis, she was started on a course of systemic steroids. She did not improve, and then there was COVID lockdown, and she vanished for a long time. And after many months, she came back with a similar eye position, and then she was taken up for surgery. And she underwent a free tenotomy of the inferior rectus of the left eye and a medial rectus recession of the left eye. And she was much better cosmetically, though she cannot depress her left eye as much. So just to come to some concluding remarks, restrictive strabismus is challenging. It needs to be individualized to the patient and managed accordingly. The aim being to improve the field of binocular single vision, to improve diplopia, and to improve cosmesis when indicated. In surgery, it's important to try and relieve the restrictions as much as possible. And it helps to have a little goal